Dr. Indranil Bhattacharya, sir, please proceed, sir.
Sure, sir. Sure. Yeah. We had a wonderful session. Thank you for handing me over for the English session. So, friends, today is a 1987th day of uninterrupted daily webinar of International Forum for Promoting Homeopathy. Today is of 8th of February 2026, 8:30 p.m. I welcome all of you from wherever you are joining. A few words about IFPH, the International Forum for Promoting Homeopathy. It is formed to bring together the global promotion of homeopathy. That is the main aim of this basically forum, and also the homeopathic movements which are going on, activities worldwide, everyone to be brought under one umbrella. That is the main intention. In the community, religion, caste, ideological, political divisions have no place. So we'll all keep in mind the purpose is only to concentrate on the field of homeopathy and to promote homeopathy. Now, witnessing the present world, I humbly said that popular in simple and less expensive way, we can treat patients with homeopathic medicines which can save their life. IFPH understands that our mission is to bring the identity to the attention of general public. To fulfill the aims and objectives, we are conducting daily Zoom webinars from September to 2020 for 3 hours. One is in Hindi, second is in English, and third is in the local language Malayalam. So almost daily we are conducting uninterruptedly. So we are very happy for that. I humbly request you to take it to yourself and become a part of IFPH by cooperating all of us. Also, there is a YouTube channel of IFPH. I basically appeal all to join the channel, to subscribe it basically, and to share it with your friends. Already happened lectures are being uploaded over there. So we move on for the today's English session. I welcome you all. Today we have got a very eminent and a senior speaker with us, and we are really happy to have sir over here. Dr. Samar Chatterjee sir will be joining us for the English session. Sir is MD in Homeopathy. Sir is Professor and HOD of Materia Medica Department, JIMS Homeopathic Medical College and Hospitals, Hyderabad, Telangana. Sir is also been examiner for UG and PG. Is a paper setter, moderator in different universities as an examiner. Is a member of drug proving committee at JIMS Homeopathic Medical College organized by CCRH. He has published articles in different journals, review of the book. He is also practicing homeopathy. He is very senior for around 39 years. He has a teaching experience of around 34 years. And today his topic is very interesting, where we all face challenges, that is beyond scalpel. Many times surgical cases are a dilemma in our mind, what to do, whether to manage or not to manage. So with a really welcome heart, I also invite sir to take over the charge. Dr. Samar Chatterjee sir, kindly start your session, sir.
Good morning, good afternoon, good evening. I'm audible, sir?
Yes, sir. Yes, you're audible. Yeah, you can go ahead. Yeah.
Respected dignitaries, Dr. M.K. Sahani, Dr. Dhanesh, Chairman of the scientific session, and today's science committee coordinator, Dr. Indranil sir, all the faculty members, सभी को मेरा नमस्कार. I would like to extend my gratitude to respected members of the International Forum for Promoting Homeopathy and the Director of JIMS Healthcare, Dr. Naveen Pavaskar sir, Principal Dr. Dhole sir, HMM Department, faculty, all the teachers of the JIMS Homeopathy Medical College, and all the teachers of in our fraternity in the world, India, and UGPG students, interns. Special thanks to Dr. Susmita. Beyond the scalpel of homeopathic management of surgical cases. I am sharing my slide. So beyond the scalpel, homeopathic management of surgical cases, today is the part 2. First is, that is the varicocele. If you consider the anatomy, you see that this is the normal anatomy of the testicular and male genital organs. And in the right side, you see that the varicocele condition. Now, it is the normal upper side picture is the normal testicle healthy veins. In the lower portion, it is surgical pathology, the varicocele testicle dilated veins. And the question is why varicocele occurs mostly on left side. We have a question, no? So varicocele predominantly affects the left side. Right side also affected, bilaterally also affected. It is due to anatomical differences in venous drainage. The left testicular vein is longer and follows a more vertical path and drains into the left renal veins at a sharp 90-degree angle, increasing hydrostatic pressure and promoting venous reflux. Anatomical reason, the right testicular vein drains directly into the inferior vena cava at a gentle angle with lower pressure, making right-sided varicoceles far less common. And sometimes it is happening 80 to 90% occur in left side, but my case is bilateral. Valve incompetence in the pampinephrine plexus vein exaggerates reflux on the left. Additional factor, the pneumocracker effect, where the left renal vein is compressed between the aorta and superior mesenteric artery, further elevates left-sided pressure. Gray's anatomies describe this venous asymmetry in testicular drainage. So this is the in the left side you see that it is a normal position of the pampinephrine plexus. On the right side it is a disease condition. Varicocele is an abnormal dilatation and tortuous of the veins with the pampinephrine plexus of the spermatic cord, most commonly on the left side due to anatomical factors. It results from incompetent or obstructed venous valves, leading to increased venous pressure and impaired blood drainage from the testes. Varicocele is often asymptomatic but may present with dull scrotal pain, heaviness, or visible swelling that becomes more prominent on standing or straining. It is a common cause of male infertility as the increased scrotal temperature, oxidative stress can impair spermatogenesis. Now, when we'll advise for surgery, what are the conditions? That is the infertility when a man with a palpable varicocele has abnormal semen parameters and the couple has documented infertility. Adolescent varicocele if there is testicular atrophy or reduced testicular growth compared to the opposite side. Symptomatic varicocele, persistent scrotal pain or discomfort not relieved by conservative measures. Bilateral varicoceles causing clinical or reproductive concern. Progressive worsen of semen quality or testicular function over time. Cosmetic and physiological concern, though it is less common. Now, complication, if you advise the varicocele operation, then what happened? Complication after surgery. That we have to think. Why we are homeopath, we'll try our level best to treat such type of patients. Hydrocele formation after surgery again recur. Recurrence of varicocele, injury to testicular artery leading to shrinkage of testis, infection at incision site, scrotal pain or swelling for a few weeks, bleeding or hematoma in scrotum, failure to improve sperm parameters in some patients, rare risk of blood clot, and anesthetic problem. Now I am going to present here, sharing the slides that about a case. A 27-year-old male presented with a complaint of pain in the bilateral testicle for the past 4 to 5 days, with a history of similar pain occurring on and off since 2023. The pain was described as stitching in nature. There was associated burning sensation and pain during micturition with no discharge. There is no history of trauma or fall. On general examination, the patient had a normal appetite with a normal desire for food and sour food, and thirst was normal, about 2 liters per day. Perspiration was more on the face. Bowel habits were regular and satisfactory. Urinary complaints included burning during urination. He was thermally hot and reported unrefreshing sleep due to occupational strain and religious prayers. Dreams were lascivious in nature. Mentally, the patient expressed anxiety regarding his health and concern about whether the condition would be cured or not. And the totality of symptoms, anxiety about health, and religious minded, offering prayers daily, desire for sour food, and burning sensation during micturition, perspiration especially on face, sleep unrefreshed, lascivious dreams, pain in right testicle, stricture and stitching type of pain in right testicle. Now, after reparation, we see that there is sulfur, staphylococcus, natriumur, pulsatilla, these drugs are coming. So further studying the mathematica, I suggest sulfur. So sulfur was given on 26th August 0/1 in that is a 60 ml distilled water, 20 drops active spirit for 15 days, and rubram is given noon and night. Next, 15th September, pain in bilateral testicle got reduced by 30%. No burning sensation during micturition, no discharge. No new complaints, GNs are improved. Then I prescribed sulfur 0/2, 2 medicated globus in 60 ml distilled water, add rectified spirit, and to be taken morning daily, followed by rubram noon and evening. Morning medicine, rubram noon and evening. No new complaints there. On 14th October, I will show you the USG of the testis later on. And 14th October, you see pain in bilateral testicle got reduced by 60%. No burning sensation during micturition, no discharge, no new complaints, general improved. Sulfur, next sulfur 0/3 given in the same way for 15 days, followed by rubram like previous. Next, on 17th November, patient reported that pain bilateral testicle got reduced by 70%. No burning sensation during micturition, no discharge, no new complaints, and generally improved. Sulfur 0/4 was given in same way for 15 days, followed by rubram for 21 days. Next, on 15th December, patient reported that pain got reduced 80% by medication, no discharge, no new complaints, generally good. Then I have given sulfur 0/5 in fractional dose in distilled water, followed by rubram. Next, patient reported me on 5th January of this year. Patient is feeling better. Pain got reduced completely. Pain on exertion occasionally. GNs good. And he came for regular checkup. Sulfur 0/6 was given. Now I am showing you that the patient in 23 October, USG scrotum done. It is the report. There, grade 4 varicocele evidence there as per investigation, ultrasound of the scrotum. Next, again, he has investigated on 19 December 23. There, grade 3 to 4 varicocele, they have remarked, and bilateral hydrocele there. So, impression on 27th October 2023, bilateral grade 4 varicocele, bilateral mild hydrocele. On 19th December 2023, impression bilateral bilateral sided mild chronic hydrocele, and right is more than the left in hydrocele, and bilateral grade 4 varicocele. Next, the patient reported me and taken medicine. So I advise USG on 20. He has done ultrasound of the scrotum on 25th October 2025, and it reveals that grade 2 varicocele after this treatment. Then, 25th October, that is the impression, bilateral grade 2 varicocele or bilateral minimal hydrocele still there. Then I advise further for investigation. The patient was reported done ultrasound of the scrotum, and it has reported the USG scrotum. It is the report on 6th October. Today is 8th. He has sent me the report in a WhatsApp. That's why I'm able to show you that now it come down grade 1 varicocele. It has been as per investigation report. So impression grade 1 varicocele, bilateral mild hydrocele. The patient will be reporting tomorrow. Tomorrow I have a OPD. There he will report me. Next case is infected keratinous cyst. A keratinous cyst is a benign, slow-growing cystic lesion arising from the epidermis or hair follicles in fundibulum, lined by stratified squamous epithelium and filled with laminated keratinous cheesy material. It commonly occurs on the scalp, face, neck, trunk, and back, and often shows a central puncture. But this term sebaceous cyst is a misnomer, as the cyst does not originate from the sebaceous gland. Now, in this condition, what are the indications for surgery? When we advise for surgery, surgical excision of a keratinous cyst is indicated in the following situation: recurrent infection or inflammation of the cyst, painful, tender, and rapidly enlarging cyst, cosmetic reason, especially when located on face or exposed area, and ruptured cyst causing surrounding inflammatory reaction or abscess formation, repeated foul-smelling discharge from the cyst, and suspicion of malignancy. But when in this condition, other surgeon or general physician, they will refer for surgery. But such type of cases came to our OPD. And before that, I want to tell you what are the complications of the surgery that we have to see. Why we go for homeopathy? Recurrence due to incomplete excision of the cyst wall, surgical site infection may chance, hematoma or seroma formation, delayed wound healing, scar formation or keloid, persistent pain or tenderness, nerve injury, poor cosmetic outcome. Then I am going to share you a case. A 30 years old female presented to the outpatient department with a complaint of a soft swelling around the umbilical region for the past 3 months. The onset of the complaint was gradual, with a slow and progressive increase in size. The patient reported that the swelling wounds start oozing on slight pressure, discharging a scanty black-colored fluid. The discharge was occasionally associated with a pricking type of pain with burning sensation, especially on touch. There is bleeding on touch. All complaints aggravated at night. There is no history of trauma, fever, or similar complaints in the past. So, based on the clinical presentation and local examination findings, the case was diagnosed as an infected keratinous cyst. And this is the corresponding to the disease code ICD-11, code L72.9. Differential diagnoses such as sebaceous cyst, umbilical granuloma, and cutaneous abscess were considered and ruled out based on the characteristic discharge, location, and clinical features. And the patient also came with biopsy report. Investigation on 17 April, biopsy of sebaceous cyst was done. Gross examination, narcotic tissue was found. Microscopy examination, multiple bits of keratin lamellae and inflex with foci showing calcific areas, bits of fibrofatty tissue with mixed inflammatory cell infiltrate seen. This is the report. Now, clinical examination. On local skin examination, inspection revealed a black colored soft swelling located just above the umbilicus, measuring approximately 2 into 2 centimeter. The margins of the swelling were smooth and uniform. On palpation, the lesion was soft in consistency, tender, and showed bleeding on slight pressure. On touch, no surrounding erythema or sign of systemic infection were noted. So the totality of symptoms, mainly the bleeding on touch, complaints aggravated at night and white touch, pricking type of pain, burning sensation on touch, scanty black discharge, oozes on touch. So I have given, considering the presenting symptoms, the nitric acid was given. So nitric acid 0/1 given, 2 medicated globus in 60 ml distilled water, 20 drops rectified spirits to be taken daily morning for 2 weeks, and associate with rubrum noon and night for 2 weeks. Next follow-up on 2nd May, burning pain in the umbilical region reduced 40%, blackish discharge reduced by 30%, Jan's health are good. Then I have prescribed nitric acid 0/2, 2 medicated globus in 60 ml distilled water and 20 drops rectified spirit to be taken daily morning for 2 weeks, followed by rubrum and noon and evening for 2 weeks. Next, burning pain in the umbilical region reduced by 60% and blackish discharge reduced by 45 to 50%. Jan's health are good. Nitric acid 0/3, 2 medicated globus in 60 ml distilled water, 20 rectified spirit given and to be taken daily morning for 15 days, and as rubrum also given BD noon and night for 21 days. Then the patient came on 13th June. Burning pain in the umbilical region reduced by 85%, blackish discharge reduced 70%, and the patient got relief. Nitric acid 0/4 is continued. Next, on 11th July, burning pain region is reduced, blackish discharge slightly present, nitric acid 0/5 again given, and rubrum also given, noon and night. Then on 14th August, patient reported me that patient feeling better, blackish discharge reduced, general good. So I have prescribed rubrum. And this is the case before treatment, the keratinized cyst, that is blackish, and just near the umbilicus you see. And after the treatment, this is the result. In the below, the result after treatment. This case highlights the effectiveness of individualized homeopathic treatment in managing an infected keratinous cyst. Nitric acid proved beneficial in relieving pain, controlling bleeding, and facilitating complete resolution of the lesion. Next, I am going for another surgical condition, that is calcaneum spur. Patient is 41 age, male, living in Hyderabad. Chief complaint is pain in bilateral heel since 2 to 3 months. History of pain complaints. Patient was apparently healthy 2 to 3 months ago. Pain started first on right, then left. Complaint started after lifting heavy weight. First started as weakness in limbs, then pain gradually, gradual weakness increased. The pain is increased. Pain has aggravated in the morning, raising after rest, initial motion and lifting, emulated by walking. Then patient, the history is typhoid 2 years back, family history, mother paralysis attack, diabetes and hypertension. Father healthy, brother diabetes and hypertension, maternal uncle diabetes and hypertension. So physical general, appetite decrease since 2 to 3 months, easy satiety, thirst, drinks water, 4 to 5 liter, excess thirst, large quantity, long intervals, desire feast, aversion shower, change of weather, nothing significant, sun aggravation, nothing significant, sleep sound, refresh, occasionally disturbed due to pain, dreams, nothing significant. Physiological examination, you see that stool regular, soft, urine clear, perspiration scant, thermal covering all season, and fanning seasonal, breathing lukewarm, weather preference summer. Conclusion, patient is chilly. Mental general. Married life 5 years, good relation with all the family members, and 3 years back he lost money in some trading apps. After losing, he felt very sad because all his savings are gone. Once he attempted suicide, and he will be having thoughts of suicide because nobody in the family knows about it. Anger of slightest matter. So this is the X-ray. And calcaneum spar, you see if you see the X-ray, I hope you can understand that there is a evidence of calcaneum spar bilateral. Now, considering the signs and symptoms, reparation done, and there is a Rastux, Ruta, Atramu, phosphoric acid. These are the drugs are coming. So I consulted Medica further, considering the other symptoms. Then I prescribed Rastux. So Rastux 200 given 2 drops in 60 ml distilled water, 20 drops RS. In fractional dose to be taken alternately morning. Then I have observed that the visual analog scale, VAS scale, when the patient came, there is a severe pain. So I want to show you that VAS scale, if there is no pain, that is 0. And very mild pain is 1, and discomforting is 2, and tolerating pain is 3, and distressing pain is 4, very distressing pain is 5, and intense pain is 6, very intense pain is 7, and an intolerable pain, horrible pain is 8, and excruciating unbearable pain is 9, and patient mostly severe and uncomfortable and cannot tolerate, that is near about 10. So in this way, the VAS scales consider, and we consider the pain. The patient is having 7 to 8 VAS scale according to VAS scale. So pain in bilateral heels still persist, pain not reduced, pain continues all day, aggravated walking, standing, appetite normal, bowel regular stool, sleep disturbed due to pain. Rastux 1 ml given, 2 drops in 60 ml distilled water, 20 drops RS, to be taken once in the morning, alternate day for 15 days. And VAS score there initially 8. Pain in bilateral heels reduced 40, all physical general normal except sleep. Sleep disturbed due to pain. Then again Rastux 1 ml, 2 drops in 60 ml distilled water, 20 drops RS given, and to be taken alternately morning for 3 weeks. And here the VAS score is come down to 7. Next follow-up on 15th July 2025. Pain in left heel reduced 60%. Pain in right heel completely reduced. All physical generals are normal. Then again I repeat that one, Rastux 1 ml, 2 drops in 60 ml, Distola 20 drops RS, and to be taken once full medicine, once alternate day. Here the VAS score, the pain is 4. Next follow-up, 8th September, pain in left heel reduced 80%, pain in right heel completely reduced. All physical generals are normal. Then I have given root burn, and here the VAS scale was 4. Then follow up on 6th October, patient reported that left heel reduced 90%, right heel completely reduced, all physical generals are normal. That's why I have given rubram. Next case is corn. The corn, the clavis is what is called is localized, painful, hyperkeratotic lesion of the skin caused by repeated pressure or friction, commonly occurring over bony prominence of the feet, toes, metatarsal heads. It has a central conical keratin plug that presses into the dermis, producing pain. Indication for surgery: failure of conservative treatment, that is pairing, keratolites, padding, footwear modification, everything is done. Still the patient is not getting relief. Severe or persistent pain interfering with walking or daily activities, recurrent corn despite adequate conservative management, underlying bony deformity like hemato, cloto, prominent metatarsal head, there is a repeated chance of producing corn. Ulceration or infection associated with corn. So neurovascular compromise or suspicion of other pathology we can think it. So if the operation done, what happened? What are the complications after the surgery? We have to know. So recurrence is the main problem. If is operated out, again another root cause will not disappear after operation. So there is a chance of recur. Infection, delayed wound healing, scarring, persistent pain, altered sensation, nerve injury, stiffness or deformity of toe. This is the complication that we have to think. Now I am sharing a corn case that is a surgical, apparently surgical case. We are treating by homeopathic medicine. A 38-year-old married female housewife by occupation came with history of irregular, scanty menstruation, overweight, presented with a complaint of painful and itchy corn on the right sole for the past 1 year. The condition developed gradually following the regular use of hard-soled footwear. The skin appearance was rough with pricking pain, aggravated while walking at night and relieved by rest. She had a significant past medical history. Family history revealed hypertension, diabetes among grandparents. Her appetite was satisfactory with a marked desire for sweets. Thirst, bladder, sleep, and perspiration were normal. Bowels usually hard, constipation, menstrual history was irregular, with leukorrhea occurring 2 days before menses. An abdominal and back pain during menstruation. She was chilly patient thermally. On life space investigation, the patient belonged to a middle class socioeconomic background and reported interpersonal stress due to issues with her mother-in-law. She experienced anger but habitually suppressed her emotion. She had a long-term history of suppression of grief and sorrow. General and systemic examination were within normal limit. Local examination of the right sole revealed a Yolis raised thickened lesion. There are two sites of lesion with a central core on the arch of the foot, which was hard and tender on palpation, with no signs of inflammation or discharge. Based on clinical findings, the case was diagnosed as corn on the soles of the right foot. Next, the totality of symptoms. Corn on right sole, corn painful aggravation on walking, night, emulsion by rest. Skin eruption, Yolis, hard, tenderness in sole while walking, itching around the corns, soreness, skin sole overall thickening, rough appearance, chilly patient, constipation, irregular menses, desire sour food. Then, considering all signs and symptoms, the totality, I have given graphitis 0/1. 2 medicated globules in 60 ml distilled water, 20 drops actified spritz to be taken daily morning for 2 weeks. And rubrum is given noon and evening daily. Then patient reported me on 25th February 2025. Pain reduced by 20%, no such improvement. Graphite is 0 by 2. Then I have given 2 medicated globules in 60 ml distilled water, 20 drops rectified spirit to be taken daily morning, 1 spoonful on alternate days for 3 weeks, followed by rubram noon and evening, 3 weeks. So next is follow-up is 24th March 2025. Picking type of pain in right sole aggravated by walking on barefoot reduced by 40%. And size reduced only 10%. Graphite is 0 by 3 and the structure is becoming soft. 2 medicated globules in 60 ml diluted distilled water, 20 drops rectified spirit to be taken daily morning, 1 spoonful on alternate days for 3 weeks. And rhubarb also given. And on 15th April, size reduced 30%, pain is reduced 60%, and general health are good. Graphite is 0.4 was given in similar way for alternate days to be taken in the morning, 3 weeks, and associated with rubram noon and evening. On 6th May, pain is reduced by 70%, size reduced by 50%, thickness and hardness reduced. Then I have given graphite is 0 by 5, 2 medicated globules in 60 ml distilled water, 20 drops rectified spirit to be taken daily morning, 1 spoonful on alternate days for 3 weeks. And rubram also as it is noon and night to be taken. Advice. On 3rd June, pain is reduced 90%, size reduced 70%, 75%, thickness and hardness reduced, and corn is soft. Then I have given graphite is 0 by 6, 2 medicated globules in 60 ml distilled water, 20 drops rectified spirit, and to be taken alternate days for 3 weeks. Associated with rubram noon and night for 1 month. And this is the patient's condition. There are 2 lesions before treatment. After treatment, there is a reduced growth and pain. Now I am going to share you another surgical pathology case, that is cervical spondylosis. Cervical spondylosis is a degenerative condition of the cervical spine, characterized by age-related wear and tear of the intervertebral disc, vertebral bodies, unconvertebral joints, and vertebral joints, and facet joints, often associated with osteophytes formation. It may lead to neck pain, cervical radiculopathy, or cervical myelopathy due to compression of nerve roots or the spinal cord. Now the condition, what are the indications for surgery of such condition? You see, the surgical management is considered when conservative treatment fails or when there is significant neurological complaints arises. Then indication includes cervical myelopathy, progressive weakness, gait disturbance, hand clumsiness, bowel or bladder involvement, persistent cervical radiculopathy, severe arm pain, numbness and weakness, symptoms persisting despite adequate conservative therapy, progressive neurological deficit, worsening motor or sensory deficits, radiological evidence of spinal cord or nerve root compression, disc herniation, osteophytes, spinal canal stenosis correlating with symptoms, cervical instability or deformity, kyphosis, and listhesis causing neurological compromise. So in this condition, we are supposed to advise for surgery. But the problem is, after surgery, what are the complications we have to see? Early complication, surgical site infection, hematoma causing airways compromise, and dural tear and cerebrospinal fluid leakage, CSF fluid leakage, neurological deterioration, recurrent laryngeal nerve injury, hoarseness of voice, dysphagia, and late complication, adjacent segment degeneration, implant failure or loosening, non-union, and persistent or recurrent pain post-laminectomy kyphosis, especially after posterior procedures. So, in this case, I am sharing a cervical spondylosis case. The patient came attend the OPD, aged about 56 years old female, presented to the outpatient department with complaints of pain in the nape of the neck with stiffness for the past 1 year on and off. Pain was insidious in onset, gradual progressive in nature, and radiated to both upper limbs. And also pain is radiating to temporal, vertex, occipital region. It was aggravated by lifting heavy objects, physical exertion, amortization by rest, and was associated with numbness sensation in both upper extremities. The patient physical journals revealed that her appetite was normal with moderate thirst. She preferred warm food and drinks and had an aversion to cold exposure. Her bowel habits were regular with normal consistency and frequency of stool. Bladder function was normal. Sleep was disturbed due to pain in the neck, especially during the night. And she frequently changed posture to obtain relief. Perspiration was moderate and generalized without any characteristics odor. Thermally, the patient was sensitive to cold and preferred warmth. With regard to mental journals, the patient was mild and calm by temperament. She was anxious about her health and expressed fear regarding the persistence of her complaints. She was easily fatigued by continuous pain and became irritable when the pain increased and has difficulty in concentration. Patient is conscious and well aware with time, place, and person. On general physical examination, the patient was moderately built and nourished. Her vital parameters were within normal limit with a pulse rate of 80 beats per minute, blood pressure of 130 by 80 millimeter of mercury, respiration rate of 18 per minute, and body temperature 37 degrees centigrade. Systemic examination revealed no abnormality in the cardiovascular, respiratory, abdominal system. Neurological examination showed intact higher mental function. Motor system evaluation revealed normal muscle per tone and deep tendon reflexes in all 4 limbs. Sensory examination revealed paresthesia in both upper limbs, which was aggravated on lifting heavy weights. Local examination on the cervical spine revealed restricted and painful movements in all directions. Tenderness was elicited over the cervical region on palpation. Radiological evaluation with X-ray of the cervical spine in anteroposterior and lateral views demonstrated anterior osteophytes formation with narrowing of the intervertebral disc space, suggestive of degenerative changes. So this is the X-ray of the patient. So this is a case of cervical spondylosis. The patient X-ray done on 23rd December 2024. Next, the cervical spondylosis totality of symptoms. Patient having difficulty in concentration, irritability is there, chilly patient, pain in neck, drawing pain type, pain in nape of neck with stiffness, pain in nape of neck radiating to temporal vertex, pain aggravated on physical strain, numbness sensation in the upper limbs, sleep disturb due to pain. So the reparation done, and there simiciluga, I mean Acterissimusa, Chelidonium naxomica, and phosphorus, some other drugs are given. So I consult the mathematical further, and I have decided to prescribe Acterissimusa because Acter I have found since my last 39 years practicing experience, it has found that Acterissimusa has a great role in the cervical spondylosis, the cervical region pain. So I have given Acterissimusa 30 OD 3 days followed by Rubram for 3 weeks. Then the patient came on 23rd December, and initially she had the pain, vast scale intensity of pain 8 out of 10. So severe pain. And clinical findings, restricted and painful cervical movements. Actiarisimosa 30, again given for 3 days, followed by rubrum for 21 days. Next, on 21st January 25, a patient reported that pain slightly reduced, numbness persists, general are normal, and here the VAS scale considered on the basis of pain, it is 6. The mild reduction in tenderness, actiarisimosa even given 30 power and followed by rubrum. Next, 25th February 2005, pain moderate, numbness reduced, Janssen normal, and pain Vascal, according to Vascal, the pain come down up to 5. So it is a mild to moderate pain, improved neck movements, actiarisimosa 200 given, because the patient is taking too much time for curing. That's why I need the higher potency actiarisimosa 200 OD for 3 days, followed by rubrum. Then on 22nd April, patient complains that pain mild, occasionally numbness, generals are normal, and Vascal, just I am considering the pain management. The Vascal score is 3. Minimum tenderness, movement better, actiarisimosa 200 again given for 3 days and followed by rubrum. Next, on 9th June, the patient came and reported me no radiating pain, numbness absent, generals are normal, and the localized pain is little bit there. That's why VAS score is come down 1. Near normal cervical movements, and rubrum is given as the patient was reported to normal. Now the last case is ligament tear. You see that a ligament tear, partial tear, not complete tear. A ligament tear is an injury involving partial and complete disruption of fibrous connective tissue that stabilizes a joint. It commonly occurs due to sudden trauma, twisting, overstretching, or direct blow. How it has happened, leading to pain, swelling, joint instability, and restricted movement. Common sites include, usually the ligament tear occurs commonly on knee, ankle, and shoulder. Types of surgery based on severity and ligament. When surgery, what are the surgery required? And actually ligament repair and suturing of torn ligament. Ligament reconstruction, mainly the complete ligament tear and advanced stage condition, we need to surgery. Replacement using autograft, orthoscopic surgery. And now the indication of surgery, I am telling you, complete ligament tear, persistent joint instability, failure of conservative management, physiotherapy, dressing, and bandage like that. Young active individuals and athletes, recurrent episodes of joint giving way, associated injuries, meniscal tear, cartilage damage, functional limitation affecting daily activities. There we are advising surgery. Now, what are the role of homeopathy? We are discussing later. Complication of ligament of surgery. What happened? Infection and delayed wound healing, that is happening. Complication, bleeding, hematoma, swelling, post-operative pain and joint stiffness, graft failure occasionally, persistent joint instability, neurovascular injury, deep vein thrombosis, early degenerative changes of the joints. Now, I am sharing you a respected audience, the doctors. Please, I am sharing a case about the partial ligament tear. A 64 years old female came to the OPD with the complaint of pain in the left knee joint since 7 days. The pain followed after an injury, fall from the bike. Pain is very severe, can't move her left knee and pain in aching type. The part is very sensitive to touch. Left knee joint feels as if it was sprained. Aggravation while moving the left knee, exertion, ambulation by rest, pressure. She had been to allopathic hospital and there she was diagnosed as a case of ligament tear. She is a hypertensive and on regular medication since last 7 years, and the past history revealed hypertension, diabetes among parents, and her son is of 42 years. This is a aged person. Her appetite was satisfactory. Thirst, bowel, bladder, sleep, and perspiration were normal. She was ambithermal. She has sleeplessness because of the pain since 7 days. Mentally, she was very worried about her condition and repeatedly asking for solution of her condition. On general examination, the patient was moderately built and nourished. Her vital parameters were within normal limits. Pulse rate, blood pressure, more or less, blood pressure is 140/90, and she was on under medication for hypertensive drug. This was normal. System examination revealed to no abnormality in the cardiovascular, respiratory, abdominal system. Neurological examination shows higher mental function is okay. Local examination of the left knee joint on inspection and blackish blueness near the lateral side of the knee revealed restricted and painful movements in all directions. Tenderness was elicited on palpation. Severe pain was observed with regard to a VAS scale, that is 8. Moderate to severe pain. Radiological evaluation with MRI left knee revealed moderate hemoarthrosis, degenerative arthritis, changes near complete tear involving proximal and mid portion of collateral ligaments, distal portion, flap tear of the posterior horn of medial meniscus. And this is the MRI scan of the patients in the affected area. So, totality of symptoms after injury or fall: pain in left knee joint, aching type, pain as if sprained, aggravation by touch, exertion, ambulation by rest, sleepless since incident, blackish discoloration of the joint or hematoma, ligament tear of the knee joint. So, considering all this condition, there is a blood clot and bruise condition and very painful and not allowing any touch. So I have given hypersensitive condition, painful condition. So arnica 200 given morning, evening for 3 days, 6 doses, and advise bandage on affected area, advise complete bed rest. And here the VAS scale was 7 to 8. Next, on 12th June, the patient reported pain in left knee decreased 10%. Pain as if sprained, unable to walk and move joint, sleep better, refreshed. Then I prescribed Ruta. Ruta 200, 2 drops in 60 ml distilled water with 20 drops rectified spirit, 1 tablespoon alternately, 1 day alternately for 21 days. Here bed rest advice, bandage for knee joint, restriction movement, VAS score is come down up to 6 out of 10. So on 15 July, pain left knee joint reduced by 35%, and Ruta 1M 2 drops in 60 ml distilled water with 20 drops in rectified spirit, 1 tablespoon alternate day for 21 days. Here VAS scale score is come down to 4, and Rubram 21 days was given. Then 24th September, pain in left knee reduced by 30%. All channels are good. Ruta 1M, 2 drops in 60 ml distilled water with 20 drops rectified spirit, 1 tablespoon, 1 spoonful medicine, 1 day alternately for 30 days. And VAS score is near about 4. So on 6th November, pain in left knee joint reduced by 80%. All channels are good. Rubram was given. VAS score come down to 1. Here the restricted movement use and crepe bandage in the affected part for 3 months. So this is about my case presentation. Over to our science coordinator and chairman.
Yes, sir. Yeah, we had a very nice session from you basically we enjoyed where we can give homeopathic treatment for surgical cases, because it is always a dilemma in our mind. Only the time is remaining less. In a minute, I would only request
Yes.
you, can you define the VAS intensity? Because we decide the pain upon that in a
Pascal.
minute. So it will be
I,
very
I
helpful
have,
for us.
yes, I have shown you in a slide that if there is a no pain, that is Pascal score is 0, no pain. If there is a mild pain, there is 1.
Okay.
1 to 2, and in that is more than mild average pain, that is 2 to 3. This scale is can be considered, and this moderately pain is there, then 4 to 5, and then moderate to severe, then 6 to 7, and the intense severe pain, that is 8, and more intolerable pain is 9 to 10. You can consider in this scale in this way. So you can measure the pain
Intensity upon that.
management.
Okay. Yeah, Takani sir, can you ask you raised a hand? Yeah. Takani
Uh,
Jerry sir, can you
Yes.
Yeah.
hear us? Yeah, we have unmuted you. You can ask your question.
Thank you very much for this nice presentation. First, I'm not familiar for your posology convention. What is rubrum? I cannot find in any place. It seems like placebo, right?
Placebo actually to please the patient. Pain medicine given for 3 days or 4 days. And
Okay, then
other days I have given placebo because to please the patient. If you don't give any medicine, patient will say that no medicine, how will recover? That is a
okay,
question to the patient.
okay. There
That's
is
why I'm given rubram, placebo.
one clarification: 444 or 4/4. What is the difference between these
Four
two?
globules, sir, 4 globules equal to 1 dose. That's why 4 I am indicated in short. 4 globules equal to 1 dose. The rubram, 1 gram globules in rectified spirit only, no medicine. So you advise the patient 4 globules equal to 1 dose to be taken. If the original medicine to be taken in the morning session, so I advise the 4 globules placebo to be taken noon and night to please the patient that she is taking or she is taking medicine.
So rubrum also taken in liquid form?
Liquid form you can prescribe. Suppose you take the distilled water only and put the rectified spirit, no medicine. And the patient to be taken 1 spoonful medicine in the noon and evening. As per your direction, you can prescribe.
One more clarification. When you use liquid dose in LM scale,
Yes.
do you suffuse before every usage?
Many times I have been practicing since last 39 years. I have most of the cases, especially the pain, the rheumatism, asthmatic trouble, and skin disease. There is a chance of aggravation where I am using the LM potency, as because I can regulate the dose by LM potency. Otherwise, suppose you have used 1M, 10M, you have to wait for a long time. That's why in that situation, when there is a possibility of aggravation, there you better to use LM potency, sir. Thank you, sir, for your question.
Thank you, sir. Thank you.
Thank you, sir, for your question.
Sir, actually, because of the time limitation, we have to wind up the session. So I would like to thank Dr. Samar Chatterjee, sir, for his valuable all knowledge which he has shared to us, and because from his very vast experience, and really we are enlightened with his good knowledge and experience. So I thank Dr. Samar Chatterjee, sir, and all the attendees. And I would like to hand over the session for our
Thank you all.
Malayalam session.
Thank you, Namaskar.
Thank you, sir. Thank you, sir.
All the
Thank you.
participants, Namaskar. All the participants.
Thank you, sir.
Thank you.